what I planned to tell in the beginning, Dr. Sai told that it's a very long topic which includes both the clinical examination as well as the imaging. I don't know whether I will be doing justice to the topic. So straight away going into the topic. For clinical evaluation, you have different techniques. A slit lamp biomicroscopy using a 78 or a 90 diopter lens remains the ideal technique for evaluating the optic disc. The advantage is it provides a stereoscopic view of the fundus. Direct ophthalmoscopy can be used when you do not have access to slit lamp. It provides a magnified view of the disc. Indirect ophthalmoscopy provides a wider view of the retina, but the finer details of the disc can be missed. And of course, the optic disc photography is important in documenting and monitoring the progression. And while examining the optic disc, what are the points to be looked for? One is the shape and size of the disc, cup size and shape in relationship to the optic disc size, neuroretinal rim, look for optic disc hemorrhages, nerve fiber layer defects, parapapillary atrophic changes, and arteriolar changes. So coming to disc size, normally the disc size is measured in terms of vertical disc diameter. Normally the disc is vertically oval, the vertical diameter being 20% larger than the horizontal diameter. The usual range is 1.6 to 2 millimeter. Anything less than 1.5 millimeter is considered as a small disc, and anything more than 2.2 is considered as a large disc. Clinically, how to estimate the disc size? For this, ideally through a dilated pupil, you can focus the vertical beam of the slit lamp onto the retina, then decrease the beam height so as to coincide with the disc margin. The corresponding reading can be obtained from the slit lamp graticule, and depending on the condensing lens which you have used, you have to use a correction factor. It is 1.3 for the 90 diopter lens, and for the 70 diopter lens, it is 1.1. So what is the significance of the optic disc size? Large discs tend to have larger cup, and small discs tend to have smaller cups. So a large disc having a cup disc ratio of 0.6 or about 0.7 or even 0.8 may be normal, whereas small discs with glaucoma can have small cups. For example, see this disc. It's a small disc, cup disc ratio is only 0.5, but see there is a superior thinning. This another disc, CDR ratio is only 0.2 or 0.3, but you can see a wedge RNFL defect over here. Now, the cup disc ratio, it is the ratio of the disc diameter to the cup diameter. Only less than 10% of the normal population do have a cup disc ratio of more than 0.5. So, anything more than 0.5 has to be watched with suspicion. Again, take into account the size of the optic disc. Large discs can have large cups. Then the next parameter is CDR asymmetry. CDR asymmetry of more than 0.2 is suggestive of glaucoma. Here again, make sure that you are comparing discs of similar size. For example, see this. Here the right disc has got a cup disc ratio of 0.5 or 0.5 maybe. The left disc, the cup disc ratio may be around 0.7 or 0.75, but see there is a disparity in the disc size. The right disc is smaller than the left disc. Now coming to disc shape, typically it is vertically oval, but it can be round, horizontally oval, more vertically oval. It can be torted, tilted, or it can be bean-shaped disc, high myopic disc. What is the significance of abnormal disc shape is that whenever you come across abnormal disc shapes, just document it. Take an optic disc photograph. Only through serial monitoring, you can pick up glaucomatous changes in this abnormal shaped disc. Eisen rule is applicable only to the vertically oval disc. The most important parameter to be examined as far as glaucoma is concerned is neuroretinal rim. Neuroretinal rim loss from the inner edge of the cup is the cardinal feature of glaucoma. For this, first, you must learn to identify the neuroretinal rim correctly. Keep in mind that it is not the color of the cup that marks the boundary of the cup. It is the bending of the vessels which mark the boundary of the cup. See, these blue arrows where you have the second kink of the vessel is the boundary of the cup. Usually the neuroretinal rim follows the Eisen rule. Violation of the Eisen rule. Neuroretinal rim changes in glaucoma can be in the form of diffuse thinning, it can be focal thinning, it can be notch. Here you have a superior notch with a superior RNFLD and corresponding an inferior field defect. Now rim color, see typically the optic disc has, the neuroretinal rim is yellowish orange, orangish pink in color. Even in advanced glaucoma, the color of the neuroretinal rim is preserved. But whenever you come across pallor of the rim, you have to think of other causes. Now, optic disc hemorrhage, it is one of the most commonly missed finding in clinical evaluation. Studies have proven that optic disc photography is more effective in picking up optic disc hemorrhages. In glaucoma diagnosis, always look for disc hemorrhages, and whenever you come across disc hemorrhages, please do rule out glaucoma. You can get disc hemorrhages in other conditions like papillitis, vein occlusions, diabetic and hypertensive patients, but when you come across an isolated disc hemorrhage, please do keep the patient under follow-up and to rule out the development of glaucoma. And as far as glaucoma is concerned, disc hemorrhage is a bad prognostic sign. It usually precedes visual field defects and retinal nerve fiber layer defects. It's more commonly found in normal tension glaucoma. And disc hemorrhages, they usually disappear in a time period of 4 to 8 weeks. Now coming to RNFL, how does the normal RNFL look like? They are usually seen as fine striations arranged in bundles, the superior arcuate and the inferior arcuate being the more prominent. For examining the RNFL, you have to dilate the pupil and use a red-free light. RNFL defects can be in the form of slit-like defects, wedge defects, diffuse atrophy or total atrophy. Slit defects, they need not be pathological always. Then you can have wedge defects as shown in this in glaucoma. Then how to differentiate between healthy RNFL and diffuse RNFL loss. See the image on the right side. See, in normal eyes, the retinal vessels, they are actually embedded in a thick layer of RNFL. So they are not very prominent, they are not very bright red in color. But when the RNFL is thinned out, they are covered only by a thin layer of internal limiting membrane, making the vessels very prominent and bright red. Through experience, you can learn to pick up these changes. In parapapillary atrophy, alpha zone and beta zone is there. Beta zone changes are more common in glaucoma. And considering the clinical significance of optic nerve head signs, neuroretinal rim changes in the form of diffuse thinning, notching, RNFL defect, and disc hemorrhages when associated with other factors are strong indicators of glaucoma. Now let me move to imaging. Actually, you can have different imaging modalities, OCT, HRT, GDX. OCT is the one which is more commonly used. OCT itself, you have different generation, time domain, spectral domain, swept source. Spectral domain is the one which is popular as of now. In spectral domain itself, you can have different machines. One thing to be noted is that each machine has got its own scanning protocols, and you cannot compare the printout of one machine with the other. Now, I will be restricting my discussion to how to read a Cirrus OCT printout. So, in glaucoma, you can have different scanning protocols for OCT. One is the optic nerve head analysis, which uses 6.4 millimeter radial scan around the disc. In RNFL analysis, uses 3.4 mm circular scan centered on the disc, and macular analysis uses radial scan centered on the fovea. OCT GCC is very significant in myopic patients because in them the RNFL is already thinned out and you may not be able to pick up glaucomatous changes in these myopic patients. In these situations, OCT GCC may be helpful. Now coming to reading the OCT printout, you have different zone. First is the patient data zone. Demographic features can be obtained here. Enter the date of birth correctly. Otherwise, while you use the normative database, errors can occur. For a good scan, you should have a good signal strength. For Cirrus OCT, the signal strength should be more than 6. Then you have the RNFL thickness map. Here, the RNFL thickness map, the machine measures the RNFL thickness and the color coding is given. Thicker RNFL is indicated in the warm colors, that is the red and the yellow, and the thinner RNFLs are indicated in shades of blue. So where do you get the thicker RNFL? The RNFL is thicker in the superior and the inferior quadrant. So you get a butterfly pattern of hot colors in a normal patient. Whereas see this, in this here there is an inferior thinning, and you can see from the thickness map that this hot color is missing. Hot color is missing in the RNFL thickness map. Now, you can have something like this in the RNFL thickness map, black areas in the RNFL thickness map. These are areas which are not imaged by the machine properly, and they are not taken up for averaging out the values. These can occur when there is vitreous opacities, which can block the correct imaging of the RNFL. Then below that you have the RNFL deviation map that is obtained by comparing the RNFL thickness map with the normative database. When it is normal, it does not give any color coding. That is when it is within the 95% of normal population range. Yellow color indicates only 5% of the normal population do have such a value, and red indicates only 1% have such a value. Then you have the testnet graph for the, there are two testnet graphs, one for the neuroretinal rim thickness and the other for the RNFL thickness. Usually it does have a double hum pattern because the RNFL is thicker in the superior and the inferior quadrants. But when there is thinning, as shown in this example, you can see that RNFL, the graph is dipping into the red zone. Even in the testnet graph for the RNFL thickness, it is dipping into the red zone. Then you have the quadrant and the clock cover maps where the machine averages out the value for each clock cover and quadrant, and the color codings are given. Then you have the table of key parameters. You need not memorize the values for this. The color coding is given by the machine itself. Then you have the extracted horizontal and vertical tomograms. What is its significance? The significance is that whether the machine has identified the optic disc margin correctly can be picked up from this, whether the Brooks membrane opening has been correctly identified. Then you have the RNFL calculation circle, which is a reliable criterion for good centering. It helps to find out segmentation errors in certain vitreoretinal interface diseases such as epiretinal membranes. The machine may not correctly identify the RNFL. Those errors can be picked up from the RNFL calculation circle. So let's see one example. This is the OCT printout of a 48-year-old male patient. Intraocular pressure was 23 and 20. See, you can pick up the RNFL defects in the fundus photograph and analyze the corresponding changes in the OCT printout. See, in the in the RNFL deviation map, these wedge defects have been picked up, but when you come to the quadrant and the glaucoma map of the left eye, see, even if there was a wedge RNFL defect over here, it has been missed out in the glaucoma and the quadrant map. This is an example of green disease where the machine may miss certain findings when it averages out the values. So you can have different fallacies while interpreting the OCT printout. You can have green disease, red disease. For the lack of time, I'm not going to the details of this. So to conclude, clinical evaluation is the first and the most important step in the diagnosis of glaucoma. OCT can complement in the management of glaucoma. Your clinical evaluation, the intraocular pressure and the perimetry are the most important tools as compared to OCT. OCT has to be always be judged with caution. Thank you.
Thank you, Dr. Litta. Very fast. Trying to finish so many things in a very short period of time. Excellent presentation. I think you because of lack of time, you couldn't speak about the floor effect and all those things. Disc hemorrhages, you have mentioned the importance of disc hemorrhage. I have seen quite a few disc hemorrhages in routine PVD, in posterior vitreous detachment, where you get a disc hemorrhage without any other glaucomatous finding. And just because it's you see a disc hemorrhage, I don't think we should feel that it is a very bad prognostic sign. That's what I feel. It is one of the indicators that the disease is progressing, or your treatment is not enough. But a disc hemorrhage by itself does not mean that this patient is going to go blind. I think that message should not be sent across. Any comments, John?
Dr. Litta mentioned about the artifacts while scanning. So that is one thing which all of you should look at. Sometimes it will be just artifacts and you have to repeat a scan. You have to put lubricant eye drops and repeat the scan. That might reduce some of the artifacts. So don't look just at the green or red part of the scan. Look at the complete scan, redo the scan if necessary before finalizing, and do perimetry.
Can you give a mic to madam?
Don't just look at the printout. Okay, you have the software where you can access it from your desk in your clinic, or go to the machine, because sometimes the segmentation is inaccurate. So you have to go back and check. Whenever you feel clinically the OCT findings are not correlating with what you are seeing or with the perimetry, go back to the machine, check the image, check the segmentation, and then only you base your decisions on that.
Other than OCT, the rest are all history? Dr. Maheshwari? We spoke so much about the GDX and
No, no, it's not about that. I think the newer generation OCT really going to play a new role, like the substitute OCT. Apart from, you can go to the OCT angiography, though I still feel they are in the beginning stage. lot of improvement has to be done, but definitely in the future we have the good OCT angiography. Probably we can detect glaucoma much earlier.
Thank you. So we come to the end of the first session. I thank the organizers for having me and John as chairman and moderator of this session. Thank you very much.